talk about the classification of different types of epilepsy presentations depending on different types of seizures that in turn depend on where the abnormal brain activity happens. So first we divide seizures in focal and generalized. Generalized take up the whole of the brain, both sides. Focal seizures happen only on one side of the brain at a very specific area and cause very specific symptoms depending on that area. So for focal seizures, we divide them in aware and in impaired awareness seizures. And this is depending on whether the patient loses consciousness during the seizure or not. Other names for these are aware, also known as simple, and impaired awareness, also known as complex. Now, classifying focal seizures depending on the area where the abnormal activity happens is the commonest and most useful form of classification we have. So, talking about the frontal lobe, abnormal activity in the frontal lobe will cause either abnormal movements or behavioural changes. And this is because if we think about brain anatomy, the motor cortex is in the frontal lobe, the back of the frontal lobe, and the front of the frontal lobe is responsible for our personality and decision making. So that explains why these symptoms happen in frontal lobe activity. Parietal lobe is where the sensory cortex is, so it will cause sensory symptoms like tingling or numbness. And in turn, the occipital lobe is where the visual cortex lies, so it will cause visual symptoms, particularly flashes and abnormal shapes in the visual field. The temporal lobe is slightly more tricky. It can cause three types of symptoms, either altered higher function, which could be things like amnesia or hallucinations of any sense or delusions, or it could be autonomic symptoms, and autonomic symptoms can include vomiting, can include flushing or altered heart rates. And the last type of symptom for temporal lobe epilepsy is automatisms that include flinching or lip smacking. Abnormal brain activity in the central sulcus, which is the area of the brain that divides the frontal lobe from the parietal lobe, causes what we call benign Rolandic epilepsy. This is a syndrome of epilepsy that's worth knowing, as is the commonest type of epilepsy in childhood. It makes 50% of all childhood epilepsy. The presentation includes facial or oropharyngeal sensory motor symptoms, which means either facial twitching or lip smacking or hypersalivation and drooling, or facial numbness or tingling. Primarily, these symptoms come up at night, and the parents would observe the kid while they sleep, soon after the kid goes to sleep, but it can also happen during the day as well. Moving on to generalized seizures, there are 4 types of generalized seizures. The first one is a generalized tonic-clonic seizure, and this is the more severe manifestation of seizures in the spectrum. And as we said, it features loss of consciousness, muscle stiffness, rhythmic jerky movement, and then the postictal phase, which is the prolonged recovery period where patients are confused and drowsy, tongue biting, and fecal and urinary incontinence. The other important type is myoclonic seizure. This is a sudden jerky movement of bilateral limbs. It's important that it's bilateral because that means that this is abnormal activity in both hemispheres, and this is why it's classified under the generalized seizures. The next one is atonic seizures, and this includes a sudden, brief loss of muscle tone that leads to a fall. So that's a typical scenario. And finally, we have the absent seizures. It's very characteristic, it's very child specific. It's a behavioural pause that's defined that lasting less than 10 seconds, and that's quite important, and for exams as well. So moving on to management, Obviously, choosing an anti-epileptic medication or a combination of these in children is a very complex decision. It's not made by people who are at our junior level. This is made by specialists. However, there are some general rules about anti-epileptic use that we all need to know. So for focal seizures, the anti-epileptics that we use in children are carbamazepine or lamotrigine. For generalized tonic-clonic seizures, we use sodium valproate. And for absent seizures, we use either sodium valproate or ethosuximide or lamotrigine, so one of the three. It's worth bearing in mind that most anti-epileptic medications cause quite a few side effects. We won't have time to cover these in this topic, but they do not require any routine monitoring when given to children. Now let's talk about complications. So complications, the main ones will be status epilepticus, accidents, and these include, for example, kids that might have seizures when they're swimming in a pool or in the sea, when they're unattended and they're next to an area where they can be injured and they have a seizure and they can't control where they fall. And another complication is the sudden unexpected death in epilepsy, and that is the commonest epilepsy-related death currently. We don't know much about this, but it's when someone that has epilepsy suddenly and unexpectedly dies and there is no other cause of death found in the autopsy. It happens mostly in people that have uncontrolled epilepsy and uncontrolled seizures, and the risk is reduced if you have well control of the condition. In terms of prognosis, the majority of childhood epilepsy goes in full remission until childhood. It's about 60% of all childhood epilepsy is in full remission by adulthood, but for absent seizures specifically, it's quite a specific child disease, so 90% of these will be gone by the time that children become 18. So let's talk about status epilepticus now. Status epilepticus is defined as a medical emergency when a patient is having a seizure lasting 5 minutes or more. It requires prompt treatment to reduce the risk of complications like cerebral hypoxia or even death. So the management of status epilepticus is divided in parts, and it has to do with how many minutes into the seizure you are. So at 0 minutes, when the child starts seizing, we check airway, breathing and circulation, and we give high flow oxygen if this is available, likely for in hospital. We also need to check blood glucose promptly to make sure that this is not a hypoglycemic episode that can be easily treated. At 5 minutes of seizure, this is the point where we define this as status epilepticus, and we need to start treating with anti-epileptics. Midazolam 0.5 milligrams per kg buccal is the first line medication, and that can be given in a hospital or a pre-hospital setting by a paramedic, a parent, or a carer. In case the patient's already in hospital and there is established IV access, we can alternatively give lorazepam 0.1 milligram per kg IV. At 15 minutes, meaning 10 minutes after we've given our first anti-epileptic medication, the next medication we should be given if the seizure still continues is lorazepam 0.1 milligram per kg IV. Remember that to give this, you need to be in hospital because you need to have monitoring in place and the ability to help. At this point, if you haven't done already, it's essential to call for senior help. The more a seizure goes on, the less likely it will stop. Now, while you're waiting for the next 10 minutes for this lorazepam to act, you need to start preparing your next anti-epileptic medication in case the seizure still goes, which is going to be phenytoin. So at 25 minutes, you should be given phenytoin 20 milligrams per kg IV, and this is a slow infusion over 20 minutes. By this time, you should have an intensive care team or a senior anaesthetist on their way, because the only next thing you can do for this patient now is anesthetize them. Obviously, the last step is going to be induction of anesthesia, using appropriate medications, but this is not a step for a junior doctor, but we need to make sure that we have asked for the appropriate help should we reach that step. So this is a summary from the NICE guidelines of how to manage status epilepticus in children. So in summary, epilepsy is a condition that predisposes to repeated and unpredicted seizures, is mostly idiopathic, and a seizure is not a uniform symptom. The presentation depends on the part of the brain that is affected. Do not assume that any seizure is due to epilepsy. Rule out other causes that are reversible and treat them if you identify them. Management decisions are complex and are made by specialists, but remember the main rules of treatment for generalized tonic-clonic, focal and absent seizures. Status epilepticus is a medical emergency. Make sure you know the treatment. Quick treatment can save lives, and it's very important for exams as well. The references are below. You can do some further reading. Thank you and good luck with exams.